Chapter 25, Bleeding and Shock. We are going to talk a little bit about the circulatory system, different types of bleeding we might see, and we're going to touch again on shock, hypoperfusion. All right, starting with the circulatory system. Here's a picture of how things flow. Okay, you can see the left and right atrium of the heart, and the ventricles. All right. All right, the main components of the circulatory system, we have our heart, we have our blood vessels, which are our arteries, capillaries, and veins, and then we have our blood. Okay. Kind of semantics here, but a lot of times when we actually use the word hemorrhage, we're talking about a severe kind of bleeding, okay? It's a major cause of shock, hypoperfusion, and trauma, and it could be internal or external. Okay, again, if we're saying somebody's bleeding, that's one thing, all right? But if we use the word hemorrhage, we're usually talking about severe type of bleeding. All right, we have three different kinds of external bleeding. Okay, we have our arteries, veins, and capillaries, and you really need to know the difference here. There will be test questions on this. You need to know the difference and what to look for. But if there's an artery that's bleeding, generally speaking, it's going to be high pressure. So remember, we talked about the arteries that carry blood away from the heart, okay? Those are going to be under pressure. So if we cut an artery, then you're going to see spurting blood, okay? You're going to see a pulsating flow, and the pulsating flow is just to the beat of the heart, okay? And it's usually a bright red color, all right? Veins, on the other hand, remember the arteries carry the blood away from the heart, and the veins carry it back to the heart. So the veins aren't going to have as much pressure behind them, but you can still lose a lot of blood from veins, all right? And so you're going to see more of a steady flow of blood, and it's a little bit darker color. And the reason it's a little bit darker is because it's deoxygenated blood. And then we have our capillaries. So when we think about capillary bleeds, we're talking like a scraped knee where it's kind of oozing out. And those are obviously going to be the easiest ones to control, would be the capillaries. Venous bleeding is usually pretty easy to control. And then arteries would probably be the most difficult. The veins and arteries, we're going to be looking at tourniquets probably if the bleeding is bad enough. But we'll talk about the steps and the protocols on how to address bleeding. Okay, so external bleeding, again, this is what's occurring outside of the body. All right, it's typically visible. How much a person bleeds depends on the severity of the wound, pressure and the size of the vessel, because all these vessels are a little bit different size, right? And the individual's ability to clot. There's certain medications that people can be on. They call them blood thinners. They don't actually thin the blood. I mean, even aspirin is a blood thinner. Doesn't actually thin the blood. It just makes them a little more slippery, if you will. The blood, I mean, and that can affect the patient's ability to clot. So massive hemorrhage. Okay, we're talking about arterial bleeding with the bright red color, spurting with the heartbeat, like we talked about. It's oxygen rich, and it's the most difficult to control. Again, with the venous bleeding, we talked about this a bit, but we'll hit it again. Darker color than arterial bleeding, it's less pressure, and the volume of blood carried by some veins can create immediately life-threatening hemorrhage, okay? And capillary bleeding is just pretty easy to deal with. Okay, bleeding can be accelerated by underlying conditions. Certain people don't have a great ability to clot just naturally. And then add to that a large group of people that are on some type of blood thinner, they wouldn't be able to clot as well. So these are things we need to think about when we are on scene. How severe is the bleeding? If it's exsanguinating, is it exsanguinating hemorrhage? If so, how does it affect the priorities of treatment? Exsanguinating is referring to a major hemorrhage where this person's going to bleed out very, very quickly, or if they've already bled out. So if we come up on scene and we see a large pool of blood, you know, we need to address that pretty quickly. And that's part of our patient assessment that we'll get into. You guys will have already had the lecture on that, but patient assessment is a big portion of this class. So we need to address any kind of circulation issues very quickly. So how does that affect the priorities of the patient? It makes them a high priority patient. Assessment and care of the external hemorrhage. Control bleeding only after assessing and treating prior elements. Direct pressure, pressure dressing, tourniquet. These are the three things. If you can just drill this into your brain and make this muscle memory, this is how you treat external bleeding. Okay, we want to try direct pressure first. Okay, and then we're going to add a pressure dressing. And if that doesn't hold, we go to a tourniquet. Now, we are allowed to skip the first two and go right to tourniquet if we feel that's necessary. It's kind of one of those things where we are trusted with our clinical judgment. If you show up on scene and somebody's bleeding out of their wrists and it's spurting all over the place, you might put a dressing on there just to hold it in place, just to kind of keep the blood flow down some, but you're probably going to go right to a tourniquet, and that's okay. It's okay to do that, but there's certain rules on the tourniquets that we need to talk about, which we will. Direct pressure. So how do we do direct pressure? We apply firm pressure to the wound with a gloved hand and gauze bandage. Okay, and we hold pressure until the bleeding is controlled. If necessary, add dressings when lower ones are saturated. So we grab some gauze and we hold it on with our gloved hand and we just squeeze. And if it bleeds through that, we can add a little bit more. Okay, once the bleeding is controlled, bandage a dressing firmly in place to form a pressure dressing. So we're going to tie it on. We're going to wrap the gauze. And when the skills nights, we will go through and we'll demonstrate and we'll show you guys how to do this. You'll practice it on each other. Never remove the bandages, even when the bleeding is controlled. Okay. When controlled, check for a pulse distal to the wound to make sure the dressing has not been applied too tightly. We want to check for a pulse just to make sure we didn't cut off circulation, unless we're at the tourniquet stage and we do want to cut off circulation. Okay. Pressure dressing, place several gauze pads on the wound. We're going to hold the dressings in place with a self-adhering roller bandage wrapped tightly over the dressings and above and below the wound site. So we're squeezing it pretty tight. We're going to take the gauze, we're going to wrap it around the bandages. We're going to wrap around the dressings tightly, and that's going to squeeze force onto the wound. Hemostatic agents, these things are pretty neat. They're not required by Part 800, but we are allowed to use them. So if your agency has them, great. They are kind of expensive and we don't use them very often and they will expire. So I think generally a lot of agencies don't buy them just because hardly ever use them. You're going to throw them away and then have to buy new ones. But they're a great tool if you need them and you have them. They're designed to enhance the direct pressure's ability to control bleeding. Hemostatic agents have like a clotting thing in there, and they make hemostatic powder that you can basically pour onto the site and it helps clot, or those hemostatic gauze, hemostatic bandages that have that hemostatic stuff in it. So when you apply the bandage, it'll help control bleeding. Works by applying a material designed to absorb liquid portion of blood and leave the other large elements of the blood so that they can clot. It's originated as powders, but does not include dressings and gauze bandages. Originated as powders. So originated as powders, but they do have the agents in the dressings now. And manual pressure is always necessary. So we're going to squeeze it. This is just an example right here, quick clot. That's got a powder and agent in it that helps to control bleeding. Okay, then on to tourniquet. Tourniquet's usually the last thing we're going to be able to do to control bleeding. If it's out of control, we're going to use a tourniquet. If we did direct pressure dressing and it didn't help, then we're going to go to a tourniquet. Okay, we use it if the bleeding is uncontrollable by direct pressure dressing. use only on extremity injury. So we're not going to put a tourniquet around somebody's neck. We're only going to use it outside of the box. So when you think about your chest cavity, they say that's inside the box. And it's a lot easier to explain in person, so I can use my hands to help me describe it. But if you think about your chest and your abdominal cavity, everything but your arms and legs, that's called inside the box. So anything outside the box, we can put a tourniquet on, okay? You know, legs, arms, wherever it needs. Always apply between the wound and the heart. I feel like that's common sense, but it's probably in here for a reason. You're not gonna put a tourniquet distal to the wound. You want to put that between the heart and the injured site. Okay, here's an example of a tourniquet. There's a lot of different types of tourniquets out there. We can make tourniquets relatively easy. You can do it with a blood pressure cuff. You can do it with a belt if you really, really needed to. But they make these commercial devices. They're pretty nice. 20, 30 bucks for a tourniquet, and it could save somebody's life. But this one here, it wraps around. Again, I don't know if you guys can see my mouse or not, but it wraps around the appendage there, and then he's cranking the handle down, and that tightens it. When we use a tourniquet, we want to go roughly 3 inches above the wound, never over a joint, okay? So meaning that you want to go about 3 inches above, but if that 3 inches is going to land on an elbow, for example, you're going to go above it. So it's a little more than 3 inches away, and that's okay, okay? Once it's applied, we do not remove or loosen the tourniquet. We do not do that ever, okay? The doctors have to do it a certain way. I think we talked a little bit about compartment syndrome, and when you cut off circulation to an appendage, the distal portion of that extremity is going to start building up lactic acid, and that's like the anaerobic metabolism we talked about, because you're not getting oxygen to that site. So you're building up a lot of junk in that extremity. And if you were to release that tourniquet quickly, all that lactic acid can shoot right up to the heart and it can cause a heart attack. So once we put a tourniquet on, we never take it off. We don't loosen it. We don't mess with it. We let the doctors do it. But the most important part about putting on a tourniquet is documentation. So we need to document the exact time we put that tourniquet on so that the doctors can remove it later in a controlled fashion, and they need to know how long it's been on there so that they can figure out their calculations for their medications and that kind of stuff. So we do everything we can to document. We document the time. We make it very obvious this person has a tourniquet. I'm telling you, if you have to take a Sharpie marker and write a big T on the patient's forehead, you can do that. It's probably not the best thing to do, but it needs to be very obvious that there is a tourniquet on the patient. Now, those commercial tourniquets that they sell, most of them have, let me go back to the other picture here. Doesn't show it on this one, but they're, most of them have a little tag on there for you to put the time. That's great. Just don't ever cover up that tourniquet either. So again, if it's on an arm, cut the sleeve right off the shirt, whatever the case is. Don't ever cover up that site, because it has happened in the past, and I've never heard of it around here, but it's happened that EMS will bring in a patient with a tourniquet on, it's covered up, doctors don't even know it's there, and then they find it later on. That person could lose that appendage because of it. So it's very important to never cover it up and make sure everybody knows that this patient has a tourniquet on. Other methods of bleeding control, we can splint. Splinting will stabilize the sharp ends of the broken bones. We can use inflatable air splints. We can put cold on there. We have cold packs in the ambulances. All right, minimizes swelling, constricts blood vessels, and reduces pain, and use in conjunction with other manual techniques. So again, our methods of bleeding control are direct pressure dressing tourniquet. Once you have that established, if you want to splint, if it's necessary, or apply a cold pack, that's fine. Just make sure that you control the bleeding itself first. Special situations involving bleeding, head injuries from increased intracranial pressure, not direct trauma to nose or ears. Stopping bleeding only increases intracranial pressure. Allow drainage to flow freely using a gauze pad to collect it. So what this slide is saying is if somebody has a serious head injury where they're bleeding out of, they maybe have a cracked skull, we don't necessarily want to stop the bleeding, because if we do and they're bleeding inside their skull, if it builds, that blood is going to keep filling up the skull, and it can kill the person from the increased intracranial pressure. So if you're suspecting a skull injury, we don't really want to apply direct pressure and stop that bleeding. Now, if somebody has a little skinned, they scrape their head and they're bleeding a little bit, by all means, control the bleeding. Okay, but if we're talking serious trauma here with a suspected skull fracture, we don't want to actually stop it. So you can apply some gauze real loose to try to collect it, or have somebody hold it near and wipe it off their face as it comes out, but we don't want to stop that bleeding, okay? Nosebleeds. Yes, people call 911 for nosebleeds commonly, okay? And how we're gonna treat that, we're gonna have the patient sit and lean forward. We're gonna apply direct pressure to the fleshy portion of the nostrils. Don't let the patient lean back. And if they become unconscious, place the patient in recovery position and be prepared to suction. So we're going to put them on their side if they pass out. And we're going to be prepared to suction in case that blood gets into their airway. Okay. Internal bleeding. So that was all external bleeding stuff. We'll talk a little bit about internal bleeding. Okay, damage to internal organs and large blood vessels can result in the loss of large quantity of blood in a short time. Blood loss commonly cannot be seen. Most of the time we can't see it, either unless they're vomiting it or they're pooping it. Severe blood loss can even result from injuries to extremities. Okay, so internal bleeding, we're talking about usually associated with trauma. We're talking about a punctured liver, or whatever's going on inside. I mean, we'll talk real quick how you can help identify that, but we don't have x-ray eyes. But if we're suspecting some kind of internal bleeding, this makes it a higher priority patient, and we need to get them to the hospital very quickly. All right, patient assessment. So this is when we talk about the mechanism of injury. Is really important for us to kind of try to figure out what's going on. Did you get smacked in the head with a baseball bat, or major car accident, far fall, you fall 30 feet off a roof or something? Okay, when we look at the mechanism of injury, that's why it's important to ask these questions and figure out what happened here. Because a lot of times we don't know what happened. Figure it out, and that can give us an idea of what kind of injuries they might have. Okay, common injury, we'll talk about, I think we'll get more into this later in class, but gunshot wounds, stab wounds, and impaled objects. This is called penetrating trauma. There will be questions on your test regarding probably something along the lines of which of the following injuries is considered a penetrating trauma. Okay, we're talking about gunshot, stabs, impaled objects. Okay, bruising is a sign of internal bleeding. If you see severe bruising around the abdomen, that could be an indicator of some internal bleeding. Patient care. So what do we do for these people, right? You can kind of say, oh, well, I can identify that problem, but it's like, now what do I do? Okay, we maintain our ABCs, and that's the most important part of our patient assessment and our patient care, airway, breathing, circulation, to make sure that's what we're talking about with the ABCs. Okay, we're going to administer high flow oxygen if we need it. And we talked about the O2 administration already. If they need it, give it to them. If they don't need it, don't give it to them. All right, control any kind of external bleeding. Take steps to preserve the body temperature and provide prompt transport to appropriate medical facility. Prompt transport, probably lights and sirens. There's no flow chart exactly when to run lights and sirens. You really need to, excuse me, sorry for the background noise. All right. There's no cookie cutter answer for when to run lights and sirens to the hospital. Most of the time we do not. I've kind of gotten away from that because they realize, hey, it's pretty dangerous to run lights and sirens and blow through stop signs and stuff, run people off the road to get a patient to the hospital when they don't need to be there right now. All right. So it's a little bit subjective. Whoever's in charge of the call, charge of the patient care, I should say, would make that decision. Okay. If you think they need to go lights and sirens, we need to get there right now, that's okay. You can do that. But a lot of patients, we don't. Okay, there's a hemorrhage control video. You guys can find this on YouTube if you so choose. This video is no different than what we're going to show you in class. Okay. Shock. Whoops, a little bit too far. Shock hypoperfusion. Again, we will be drilling shock into your head throughout class. We'll talk about it in most of the sections. A lot of different kinds of shock. All the indicators are the same as far as vital signs and that when somebody goes into shock. So that's why it's very important for us to be able to identify this. Okay. It is, by definition, inadequate tissue perfusion. It also causes inadequate removal of waste products from cells. So your body is not circulating the things that they are supposed to circulate. Okay, and there's a couple different stages of shock. So there's compensated shock and decompensated shock. All right, compensated is early on. It's when your body first identifies that there's a problem. All right, body senses the decrease in perfusion and attempts to compensate for it. Those are early, this is when we're looking for our early signs. You might see an increased respiration rate or an increased heart rate. That might just start there. Okay, decompensated shock begins when the body can no longer compensate for the low blood volume or lack of perfusion, whatever the reason for the shock is. And we'll see those late signs. So you're going to see your altered mental status. You're going to see the clammy skin. You're going to see the increased heart rate, respiration rate. You're going to see a decreased blood pressure. Again, you guys have to know these symptoms. You will be testing on it. So make sure you know the symptoms of shock. Okay. Different types of shock. Hypovolemic would be one. Hypo meaning low, decreased blood volume. Distributive. So we're talking about like septic shock. So, you got the infection in the blood. Okay. Sepsis and that. Anaphylactic shock we'll talk about later in class. We're talking about allergic reactions. Neurogenic shock, talking about issues with our nerves, our nervous system. Cardiogenic would be pump problems. So cardio is our root word there. Card, I should say. Obstructive, so there could be problems with the blood vessels themselves, and that's often grouped with cardiogenic shock. You don't necessarily need to know all the different kinds of shock. The specifics, I should say, of each of them. Know that there's a bunch of different kinds, kind of what they are. Hypovolemic is a very important one, but you got to know the signs and symptoms of shock. Okay, pediatric note. Infants and children, their efficient compensating mechanisms maintain blood pressure until half the volume is depleted. Think about that. If a kid is bleeding out, they can compensate and appear completely normal with half of the blood volume. So what that's telling us is that kids can compensate very, very well. But the problem is that when they start to decompensate, it's over. They are in bad shape. So I took a class on pediatrics a few years ago, and they're talking about how kids compensate, and they'll be fine, don't even know anything's wrong, and all of a sudden they're dead. And that's kind of what happens with pediatrics, which creates a whole nother challenge when you're dealing with kids. So keep that in mind. You got a kid who has a severe mechanism of injury. We want to take that patient very seriously because we don't know if they're compensating. We can try to determine if they are, but they might be compensating very, very well. Okay. Potential for shock must be recognized and treated before telltale signs appear. So you really got to be paying attention with kids. Okay. Signs and symptoms of shock we talked about. Okay. Transportation is an intervention. So they say, what did you do for this patient? getting them to the hospital quickly is very important, and that is something we will do. Basics for treating shock. So this is in our protocols, okay? So when somebody says, how do you treat a patient for shock? If they're showing those signs, we put them on oxygen, we control any external bleeding, we prevent heat loss, we elevate their feet, not their head. We elevate their feet. So we're gonna lay them flat, lift their feet up, and transport immediately. This is right from your protocols. This is exactly how you treat a shock patient, okay? Make sure that you know these. Okay, again, another video here. And that is it for chapter 25. All right, I will see you guys.